Well, thank you for having me today. So, we are going to be continuing on. I'm very fortunate to have followed Manny so that we can continue a little bit more theoretically about what we should worry about and what we shouldn't worry about. Before I get started, ethicists tend to have a reputation as being the bearers of bad news. In general, when I come to the party, people are not happy to see me. I work in MCDB, molecular cell developmental biology, where, amongst other things, our department does stem cell research, research into CRISPR-Cas9, genome modification, genetic engineering. We are at the cellular cusp of emerging technology, and that's where my work lives, at the cusp of emerging technologies and ethics. So, one of the things that we've hinted at, but I think that we need to situate ourselves in very firmly, is that IRBs can't protect you, and that can't protect me, and that can't protect anyone else. Not yet. So, the space that we're in is an area where all of us are here because we're committed to doing something good and helpful. Once upon a time, there were people whom you could run your research through, and they would help you determine if there were any sort of troublesome areas. That is not the space that we're in. So, because there's an asymmetry with how technology has developed and how it's being used, and the level of training of most IRBs and the kinds of concerns that they have, you're going to find that those are not good matches for you, which will raise two problems. One, you will have to answer concerns that IRBs have that you will have already solved, right? Whatever the ethical problems that they're going to ask you for, they are not going to be aware that there's good solutions to them that perhaps you've already considered and implemented. But second, it means that the burden is on you and all of us to make sure that we don't unintentionally do anything horrific. So before I get to the challenges, let's just make sure we're all on the same page about the moral greatness that you are all part of. So here are some of the amazing benefits, morally speaking, that we care about. The reasons that mobile health is going to revolutionize how care gets delivered. So some of the moral benefits are, of course, we're going to alter the way that clinical workflow happens. So right now, one of the major causes of medical errors, one of the main causes of medical mispractice and disagreement between teams has to do with communication of information and charting. So whenever you have processes that depend on lots of inefficient steps, you have potential for miscommunication. What continuous treatment, continuous charting, and changing how workflow happens, what that's going to do is help eliminate a lot of the medical errors and a lot of miscommunications that we currently face. All right, so that's moral point in the good column. Of course, we've also got potential for remote patient care. So just to make sure that we all understand the stakes of this, not only does this help us when it comes to treating patients that you might not see regularly, this also allows the allocation of resources to places where it might not otherwise go. So when we talk about remote patient care, what we're actually talking about is justice and access to healthcare. When you have a limited number of clinicians and a limited number of medical resources, allowing patients to have access to those resources, even if they don't have the ability to be right with you in the room, that's powerful. And that's a moral good. And of course, we're allowing for patient self-tracking. So mobile health alters the relationship between clinician, healthcare provider, and patient, making the patient far more active than he or she once was. That's great, right? Active patients equal better health outcomes. It also creates tools to reorient how we think about health. If we think about health primarily as interventions once disease has taken effect, there's only so much we can do. If you can intervene earlier at lifestyle interventions, preventative medicine, outcomes, and patient satisfaction are all higher. And of course, we get better data overall. So the trick about collecting data, of course, is that when we ask patients how things went, what their fevers were, what their blood glucose was, home blood pressure monitoring, we run into some trouble. The first, of course, is that people are not good self-reporters. So there's just mistakes, right? There's inaccuracies. There are also people who don't test as often as they should, who don't collect the data for themselves. But there's a larger issue. So I know several of you working with behavioral modifications for addiction. We also have a problem with selective non-self-reporting. Whenever you're working on anything that has to do with shame or stigma, you will always have higher instances of non-reporting, which is understandable, but dangerous. So all of this has the potential to revolutionize how healthcare is delivered and hopefully make things better for our patients. All right, that's the good news, right? I like to sell it to you good first. But it's not all good. So let's talk. Now, when I talk about the challenges of mobile health, I want to be clear about what I'm going to do in this talk. So I'm going to be talking about some of the greatest hits, right? Some of the greatest challenges that we're going to face in this area in general, and we're going to work through the beginning of a solution of one of those problems, at least a hint of it. But I want to be clear that not all problems belong to all people. So the problems I'm going to talk about, some are going to concern people who create policy, some are going to concern healthcare clinicians and deliverers, some are going to concern engineers, some are going to concern developers. Your particular problems will depend on your particular roles. But in the spirit of interdisciplinary work, I think it's important that all of us have our fingers on the pulse of what the larger issues look like. And that's because this work cannot happen in a vacuum. So I'm going to talk about some of the policy concerns, some of the use in the clinical setting, and some of the engineering concerns, and hopefully these are the solutions that we can come up with together. So the first major challenge actually has to do with data access. And in particular, this is going to happen not just with illicit access, right, where third parties or people who may be authorized users using things in unauthorized ways or unauthorized users in general might have access. But something else has started to emerge as we start to incorporate more mobile health and more home monitoring devices in technology in healthcare. And that's an interesting push between how patients and clinicians view this data and what kind of access people want. So here's a challenge that started to happen in the world as these technologies are being dispersed. So there's a question of how much information you should allow the users or the patients to have access to. The question forces you into one of two positions. If you allow users to actually view the fullness of the data that they're tracking, what you're doing is allowing access without the technology for analysis. So there are some very classic cases of technology where this has posed a problem. So there are very common cases of people using mobile health apps for skin cancer detection, right, for abnormal moles. So they work where you take a picture of a mole and it will scan it, look for irregular edges, and tell you if it's problematic or not. All right, so the problem, of course, is that they're not very good. So there's a huge number of false negatives. There's also some false positives. And you end up having a population who uses these applications who have inordinate amounts of anxiety over things that they really shouldn't have anxiety over. This also started to happen as people are tracking their sleep. So more and more people are using Fitbits that track sleep quality, using things that can help them determine how they sleep. And what we're starting to see is patients who reported no dissatisfaction with sleep quality are now deeply worried about problems in their sleep that are perhaps non-existent. But if I have the data, I worry about it. All right, so one option is to limit the access to the data, right? And allow patients not to see the raw stuff and only have analysis by clinicians. Then we're forced into another position. So in this position, what we end up with are patients who are deeply resentful that they don't have access to their own data, especially ones that want it. So the two cases where this has come up, and there's actually some pending lawsuits that we'll see how they come out with access to pacemaker data. So right now, wireless pacemaker data is transmitted via private machinery to clinicians via the technology that the pacemaker devices put together just for healthcare deliverers. There are no authorized access for patients themselves. There are an enormous number of patients who have worked together to hack this system so that they can see access to their own pacemaker data. And they suggest that this is their data, it's their body, they should have as much access as they so choose. The other area this has started to come up quite a bit is with sleep apnea and people who use CPAP or continuous pressure machines at night. So those store data on SD cards that clinicians can download and see sleep quality and see how things are going. But there is not commercially available software for patients to view this data themselves. So patients wrote some. So there is now open source software where you can download your own data off your own machine and not wait for your clinician's analysis. All right. So with the collection of data means we have to give some thought about what kind of access we're prepared to give patients and what kind of access patients are entitled to. This is going to involve perhaps an undoing of this great thing that we just came up with, right? An easing of clinicians' time, an ability to treat more patients. Maybe not. So figuring out where to live on this balance is a very open question. But there are some other problems. So we can talk about who owns data that is collected, but this is not actually a new question. So I'm sure many of you, if not all of you, have heard of Henrietta Lacks, a woman whose cells were collected against her will and against her knowledge. And her cell line, the HeLa cell line, has become the foundation for numerous advancements, lots of profiting, and of course, enormous educational advancement. All right. Does Henrietta Lacks, or now her family, have a right to profit from any of that research? So when we talk about data ownership, we can talk about ownership between the researchers, the collectors, the people who develop the tools. But when we talk about the commercialization of treatments or therapies that could happen when we talk about huge data mining, is it morally permissible for the patient to give up all rights to that? How should we think about what it is we're asking patients to do and what we're using from patients without their consent? When we talk about ownership, this is one of the questions we have to worry about, especially given the chance to think about finances. Don't worry, there's more. It gets worse. See, that's why no one likes me at parties. We also have questions about accountability. So things don't always go well. You may have noticed. So an open question is, who's to blame when they don't? So right now, much of our legal system is built around the idea that clinicians have primary responsibility and accountability for patient care. And that's because we have clinicians as gatekeepers against access to medical technology, treatment, data, and analysis. That is going to change. So now the question is, if the law still retains responsibility or accountability for clinicians, are we opening clinicians up to an enormous amount of vulnerability when a patient who is interpreting his or her data without training perhaps makes poor choices? We also have questions about when technology fails. Now, this is all fine and good when we're talking about counting your steps, right? And you're getting your 10,000 steps on your Fitbit. As we start to talk about implantables, as we start to talk about ways to use smart pacemakers, as we start to talk about more invasive uses of mobile technology, the potential for good, the potential for care goes up. So too do the potential for problems. So the question of who's liable and how to think about clinician, provider, computing agents, wireless technologies, deliverers of service, and the patient, him or herself, are very tricky to unravel. Part of our job is to make clear who owns what part of the process. How do I track who's accountable for each step that could go well or sometimes could not? So we talked briefly about security. This is a tricky one, not just for questions of computing and engineering, although it certainly is. But this is actually a larger question about the new relationships between researchers, clinicians, and private industry. So when we talk about trusting corporate relationships, and we talk about how to think about partnerships, There is no question that more good gets done when we do collaborate, but that comes at a cost. So right now, we have IRBs, we have steps in place, hopefully, to protect patients, but also to protect interests when it comes to most conventional research and clinical care. It's one of the reasons we have licensing requirements for clinicians. We do not have similar safeguards for the corporate world. And so what do we do? What is the appropriate partnership that we've taken so much care to protect for the last 100 years when we talk about patient care to open it up to providers of services, of technology, who have not taken the same technical steps? How does that foundationally change the relationship between patient and care provider? And is that a change we're comfortable with? And how do we make that as efficient and protective towards the patient and the provider as possible? And there are also questions about compliance. And in particular, this is a question about how this technology is going to be used in the clinical setting. So some of you are clinicians, many of you will be working with clinicians. So the question of how the technology actually starts to emerge in the patient care room has already started to present complications. So I was involved peripherally on a case recently where there was a woman who was a type 2 diabetic who was in a conflict with her endocrinologist. So the woman had a very hard time getting her HbA1c, her overall reading of blood glucose, down into a healthy and normal range. And so she presented to her endocrinologist for assistance. She had records of her blood glucose readings. She'd been keeping a food log. And she said, I can't figure out what's going on. I'm not sure what's wrong. So the endocrinologist, the clinician, looked at her readings, looked at her logs. She looked at the patient, and she was reasonably sure, given the numbers, that the patient was not recording accurately or faithfully what the patient had consumed. And so she suspected that what was going on is that the patient was either omitting or not understanding or not calculating correctly how to log what she was eating, and that was explaining some of the spikes. But the data was hard to read, looking at just the patient's testing, right? How many times can a patient test their blood glucose during the day? So she asked the patient to wear a continuous blood glucose monitor for 72 hours. So this is becoming a new standard of care where this technology is available. We use it at UCLA. And at UCLA, we pride ourselves for being very good at working with insurance companies to try to get this technology paid for because it is not cheap. But of course, the data is brilliant, right? 72 hours of continuous glucose monitoring tells us a lot about what's going on. And in this case, we thought it was patient error. The patient understood what was being asked, understood that this was patient error being suggested, and was deeply offended. So a conflict ensued. And the exact words, hard to say, it's tricky. It's one of the reasons ethicists get called in. But we'll leave it with saying the patient got the impression that the clinician was not willing to treat her unless she wore this continuous glucose monitor for 3 days. Hard to say whether that was accurate, but there is no question about how the patient felt. So the patient wore the continuous glucose monitor for 72 hours, hated it. 72 hours of misery. There's a tiny probe that rests directly under the skin. The patient had all sorts of problems with it, ended up having skin irritations with the adhesive. It was not a pretty story. And here's the exciting conclusion. So the continuous glucose monitoring showed that actually the patient's blood glucose was continuously elevated. It was not just postprandial. It turned out what this was a gum infection that was elevating her blood glucose. And it turns out that the patient was extraordinarily accurate and precise about what she was tracking. And the patient refused to see another endocrinologist in this office. All right. So when we talk about the role of how mobile health starts being used in the clinician's room, now we have a question of coercion. What is the appropriate role of this technology when, let's be honest, many of us think much of the value is that it's better than patient-reported data because patient-reported data is often not very good? How should the patient feel about that? And how should we think about the integration of that into the doctor-patient relationship when this is a relationship based on trust? How should we think about paternalism and coercion and asking our patients to wear these devices? But let's talk about what's underneath a lot of this. So when we talk about mobile health and when we talk about the creep factor, here's what we're saying. We're worried in deep ways about privacy. Let's talk about the stakes. Let's talk about what privacy looks like. So you saw just now a chart of some of the amazing things we can infer from the data that you are using when you gather for things like tracking your movement or tracking your cell phone battery. It gets worse. So here are some other things we can track, or at least we're on the potential of tracking. So you've heard this week some of the research about the first-person visual and gaze tracking. And some of you have heard about how powerful that is with the treatment of autism, right? And working with autistic children. Well, here are some of the things that research has started to delve into when it comes to gaze tracking and eye contact. We track things like implicit biases. So as a teacher, one of the things that I can be evaluated on as a professor is I can have a service through the university or outside record me and track my gaze. Do you know what it's looking for? It's looking for who I make eye contact with, whether I'm preferential towards men versus women, white students versus students of color. We can track all of that. So now we have something that we're able to discover very, very interesting information about you. Information that is different than what once used to be publicly available. So I want to be clear when we talk about privacy that we're actually talking about a few different sorts of things. So what most people think of when they think about privacy is they think about the things I don't want people to know about me, right? So things that I want to keep away from you. That, of course, is not a useful concept. So if I say, I want none of you to see me, close your eyes right now. Perhaps we don't have a meaningful concept of privacy that would encompass something like that, right? When we talk about the value of privacy, the value is not in absolutely controlling what everybody knows about me. And so much of our current legislation, with the emergence of cell phone cameras and recording and ways of policing the world through surveillance, have to do with this idea of public-private distinctions, right? This idea that when I'm in public, I don't have a right not to be seen, to impose upon all of you, close your eyes, don't look at me. We think that that's true for a few reasons. One, it's too high a burden to place on the public. But two, I actually don't have the moral authority to ask that of all of you. So it's going to turn out that in our relationship, that's not going to be symmetrical. But when we make a distinction about the private, when we make a distinction about what happens behind closed doors, then we think, now I'm making choices that I intentionally don't want to be seen by other people. That's all fine and good until technology increased. So up until recently, all of the legislation, all of the ethical debates have been about things I can know about you by being with you in person, right? I can know if you're an aggressive driver. I can know what religion you are. I could follow you on the street and see where you go. And we worry about that knowledge getting far away from where you want it to be. Of course we do. But the truth is, there are ways that I can permissibly have that knowledge about you without doing anything deeply creepy. I could just be your neighbor. And now that's changing. Now if I have data on your attention, on where it is that you are looking, on how your gaze responds to certain stimuli, on how your pulse reacts when you speak certain statements versus others, now I have access to things about you that I couldn't know just from being next to you. So it turns out we're in a new category of data. We're in a new category of privacy that we haven't explored yet. Welcome to the reason that IRBs aren't so helpful yet. So in order to adequately think about privacy, we have to think about this new category of data that has never been publicly available before. We need to think about what to do with it. All right, so option one, we could panic. Or here's another idea. I want to suggest a way to start thinking about privacy that's a little bit different. So when we talk about ethics and mobile health, we often forefront discussions of privacy when we talk about ethics above all other issues, mainly because this is where the creepy factor mostly comes in, right? This is what the public reacts to. Now, while that's interesting, I don't think it's useful. You can't solve problems by just trying to make people feel less creeped. So let's talk about how to solve problems. Let's talk about what to do with privacy concerns. What I'm going to argue and what I'm going to suggest is that we reorient the way that we approach the ethics of mobile health at both the implementation level and at the development level. I'm going to suggest that instead of worrying entirely about privacy and security, although we certainly still should, we end up putting a lot more effort into thinking about consent. And not in a trivial way. So for those of you that work in or around a hospital, that get consents or are lucky enough to have been a patient, you have signed a consent that looks like this. Stepping foot in our hospital has risks up to and including death. That's what a consent form looks like. And here's what the process of getting consented looks like, right? Often a young med student will come to you, mumble something, hand you a piece of paper, you'll ask a question, they'll be confused, and then you'll just give up and sign the paper. It's the traditional patient experience. But that, my friends, is beautiful considered the consent that most people use for mobile apps. So I've done surveys with my students. I use an anti-plagiarism software, Turnitin, and you would think that this would cause some interesting attention for students, right? That they're turning assignments into an anti-plagiarism detection software. You think they would notice that. They don't, interestingly enough. And so every quarter, I get a significant number of people who will upload plagiarized papers into the anti-plagiarism software. And at a certain point, I had to ask myself, A, it's an ethics class, so there's a certain kind of chutzpah that happens just on its own that, we're doing that. But two, they don't even directly submit it to me. It's through the software. And so I've done a little bit of informal surveying of how my students read the details of what it is they're using online and on their phones. And the answer is they don't. They don't read. They don't pay attention. But let me be clear, this is not a them problem. This is a me problem. This is an all of us problem. How many of you read the fullness of what it is that your data collection devices are going through? So I have an Apple Watch, and so I decided to spend an afternoon going through all of the fine print, looking at the data that was collected via my Apple Watch. So as I'm reading through the microscopic print that I've pulled up on my browser, I start seeing things like collect data. I'm like, right, knew that. What data are you collecting? Doesn't say. Open-ended. And the idea is the consent is meant to be covering of all possibilities, not covering of particulars. Well, so here's the thing about privacy. Privacy is not the kind of good that is good indefinitely. None of us would be better off if we were on a completely private island that no one saw us ever again and we would be completely without human contact. Privacy is what we philosophers refer to as an instrumental good. It's good because it gets us something else. So you might ask, what is that something else that we're interested in when we talk about privacy? What is the thing we really care about? Well, the answer is we care about controlling our relationships. We care about controlling our reputations. Now, you and I and other people in the world will draw that line in different places. Some of us care more about some things than others, and you know this because you're on Facebook and your friends will share things that you're like, wow. Or you are the sharer that everyone's like, wow. And that's great that people have different levels of concern. But what privacy concerns are foundationally about is about choice. How do we speak about that? Well, we speak about that by speaking about consent. So let's talk about how to center consent instead of centering privacy. So here's how to build a high-quality consent process. Here are the goals of what we're looking for. So the first, of course, we could build unicorns too, but let's talk about what a high-quality consent process would be. The first is a plain language explanation, top to bottom, of the data collection and storage. Now, the plain language is important here, obviously, but so is explaining the middle steps. So what many people understand is something like you are collecting data and then the data is going to my clinician. Right, that is not the full picture. So before I consent, we're going to have to talk to patients and users about where their data could possibly end up and how it's being transferred. It's going to involve some technology, right? And a brief lesson in how some of this works. So on the medical side, having better quality consents is something that we've been struggling with for a while. And there's various interventions and technologies that we've played with to increase the quality of consent. So one of the things that we're working with to improve consent process are things like videos, are things like non-rushed, right, pre-admission, pre-usage interactions, opportunities for patients to ask other patients questions. So when we think about all of this, these are the technologies that we're probably going to have to build in when we talk about high-quality consents. We're also going to have to talk about risk, and risk in meaningful ways. So here's the bad news. So as we're all looking at the fallout of the Ashley Madison hack, the website that very famously claimed to be unhackable, there's a question about, did users who signed up for Ashley Madison consent? Given that they were told a false claim that a website was unhackable. Of course, probably not. So what this means is some real talk, working with the patient about what it means for the fact that their data might one day become public and identifiable. This is going to reduce participation. I'm not going to lie. Part of what we have to do then is build in a quality way to talk about risk so that we don't just give a piece of paper that's up to and including death, but our version is up to and including public access. How do we talk about legitimate risk? Energy should go there. We also are going to have to talk about the things that we haven't imagined. So, in the molecular biology side, when we do cancer screenings and we do genetic profiles of various sorts of cancers, we discover unexpected findings. In testing your lung cancer, we might find out that you carry a BRCA mutation. Part of the question of consent is figuring out how to ask in advance about unexpected findings. Welcome to the world of mobile health. We don't understand what we're going to find, and we also don't understand the fullness of how it's going to be used. Mostly because that's the process. With data comes applications. That needs to be part of the genuine consent process. And of course, talking about ownership of data. This brings us to the problem of third parties, right? And talking about people who are not the users, people who are recorded or captured or innocent bystanders of the people who agreed to use the mobile health. Now, this is a huge problem when it comes to consent because either we have people who can't consent, right? It's not practical to ask everyone you pass on the street, but we're also going to have people who actively would not consent even if asked. The good news is we have tools to handle this. So when we talk about third-party consent, this is something in the medical world that we've thought about for a long time. Both when you present for clinical care unable to answer for yourself, but also when you choose to make perhaps unreasonable demands on others. So perhaps one of the things that we need to be working on is what is a reasonable standard of consent and working on that in parallel with development of opt-out markers. And so part of our challenge is to figure out how can we build an opt-out process that perhaps another individual third parties can wear on their mobile devices that will, if nothing else, broadcast a marking that there's something that is in dispute that needs to be displayed or erased. All of these are ways to start recalibrating how we think about privacy and start thinking about things more practically, thinking about what actually matters. So, thank you.